An estimated 1.1 million Kenyans fall into poverty each year. And that's because of healthcare costs. Would SHA, SHIF, UHC change that, or is there more? Or perhaps, what's the difference between a pharmacy with a blue cross and a green cross? What about cancer and the rising incidence amongst the youth? Is it just lifestyle changes, or is there more? Women's health, men's health, your children's health, the economy, this and more awaits you on Season 2 of Kenya's favorite health podcast. My name is Dr. Diana Wangari-Gitau, and welcome to Season 2 of the One Health Lens podcast. Hello, welcome to the One Health Lens podcast, Explained, where we take one topic, break it down for you. I'm your host, Dr. Diana Wangari-Gitau. Today's topic will be liver cancer, and in studio with us is our resident oncologist. I'll let him introduce himself and we'll get going.
Thank you, Diana. My name is Dr. Andrew Odhiambo. I'm a medical oncologist specializing in gastrointestinal cancers, and I'm happy to be here once again.
Thank you. Liver cancer. I mean, where do we start? It's one of those which I find to have too many things going on. Maybe let's start with a story, right? Some of the patients that you've seen, right? Maybe let's hear, as they call it, lived experience, so to speak, here.
Yeah, so liver cancer is, it's a bucket load of everything inside it. The liver is a unique organ because it can be affected by its own cancer, and it can also be affected by cancers from other organs. And many times, people will not know the difference. Okay, I'll give you an example. A long time ago, I got a patient, I think she was 90 years old.
Okay.
She went with tummy pain to the GI doctor. They did a scan and found the liver had lots of tumors inside it.
Okay.
And so they were like, hey, do I have liver cancer? So the GI doc quickly sent the patient to me. And after we finished our testing, we found out that she had a breast lump that she didn't know about, which had spread to the liver. So that's not liver cancer. That is breast cancer that has spread to the liver.
Okay.
And half the time when people are talking about liver cancer, they might be referring to a cancer that started somewhere else and landed in the
liver. Okay.
So today's topic is not that. Today's topic is cancer that started in the liver. So we call it liver cancer. The complicated name is hepatocellular carcinoma.
HCC.
We oftenly abbreviate it as HCC. Now, HCC, it can be quite complex to manage, just as the previous cancers we've been talking about, and it most often requires a big team to make a decision. But I'll just take you through maybe a story of probably what decisions we have to make. I remember during COVID, this patient came to see me. She had tummy pain for some time, and one thing led to another, and they did a scan and found a big tumor in the liver. Okay, so there was lots of emotions around it, because people, they take their report and copy paste it into Google and ask Google to give you answers, and the answers are not good. You have liver cancer, this is the survival rate, you can't do this, you can't have surgery, you can't do this. But anyway, they came, they saw me. That time you couldn't even go out of the country for treatment because of lockdowns and stuff. But after we looked at her case and we sat down with the surgeon, we sat down with the radiologist, we sat down, everybody involved in the case, and we came up with a plan. And we suggested to the patient, let's go ahead and remove this tumor, get it out of your body, and then see what's up. So fast forward, surgery was done, and it was a successful surgery. No tumor was left inside, and we were all so happy.
Yeah.
So fast forward to about a month and a half after surgery, we started noticing tiny lumps on the skin. And when we took those lumps for biopsy, it confirmed that the cancer was already spreading. You can imagine, just a month after surgery and your cancer is already spreading. So again, you have to sit down with your team, make decisions, talk about what to do. And it was very, very chaotic that time. We tried very different types of treatment, which I'll come to later. But to make this beautiful story short, is we at some point we decided to try new treatment. We call it immunotherapy. And at that time, immunotherapy had not yet been approved as first-line treatment for liver cancer. But because we tested the specimen for whether the immunotherapy could work for this particular patient, the results were very exciting. And actually, when we started the immunotherapy on this patient, all those lumps disappeared. And we completed treatment, and now she's completely recovered, and she's gone back to we just just chat on the phone, and everybody's happy, the family's happy, everybody's happy, her work colleagues are happy. So what looked like a very sad beginning turned out to be a very happy ending. And it's a story that I dream about from time to time, because it's one of those little pleasures of how successful treatment can be.
I mean, it also emphasizes how it's a very what did we say last time, individualized journey, right? It doesn't necessarily mean, say, whatever you look up online is what will happen to you or someone else. It doesn't. Everyone, there is their own pathway. And as you constantly remind us, it's about the team, because then also you have this conversation, you discuss the patient, then you figure out a plan there. Liver cancer.
So sometimes people ask me, okay, where does it come from? What are the causes?
Exactly.
Liver cancer, in this part of the world, a lot of these cancers are due to infections of the liver by viruses. And the two common viruses are hepatitis B. It's a type of a DNA virus with a lot of similarities to HIV in terms of how it's transmitted and so on. And the other one is hepatitis C. Hepatitis C is less common in Kenya. It's more common in Egypt and the north. But hepatitis B is a problem. If you were born before 2003, I think, when the government started vaccinating hepatitis B to its children, then you are not vaccinated. Millennials, you are not vaccinated. And you could be sitting at home and you have hepatitis B and you don't know. You can be a carrier. You don't know. It doesn't make you sick. You don't know. And then you get liver cancer. You get it? So there's no warning. You can be born with hepatitis B. Your mother could have had it, gave it to you. You lived a full life until you're 40 years with hepatitis B. You don't know. You're not sick. Then you get liver cancer. The stories in my diary are endless, but it's very sad that a simple vaccination could save your life. Because when you get hepatitis B and then you get cancer, you have two problems. You have the hepatitis B and the cancer. And that's like having, I don't know, it's like having fire and fire. You get my point. So it's I can't understate the importance of hepatitis B screening, checking, testing. You should know your hepatitis B status. I know mine. I have been vaccinated, and I've actually checked if my vaccine levels my antibody levels are high enough, because you should know that. All healthcare workers should be vaccinated. Everybody should know their hepatitis B status, and if it's negative, you should get vaccinated. If it's positive, you should be in a screening program so that we find this cancer early. There's a gentleman we met about 2 months ago. He just went with tummy pain to the doctor, a bit of discomfort, did a scan, boom, he has liver cancer. He has hepatitis B, which he never knew about. He has already damage to the liver called cirrhosis by the hepatitis B. And when you look at him, he doesn't even look sick. In fact, to make him believe that these are your scans, you're actually very sick, is very hard to convince somebody else. But had that particular person known their status, then we would have done something to catch it early, because there's no warning sign if you have hepatitis B. And then once you get it, it becomes quite challenging to treat it. So that's a very important risk factor. The others...
before you even go, hepatitis B, because you're emphasizing about testing, right? Would you know the estimate cost? Because, yes, the tests are available. What?
I think... I'm not sure of the current costs, but I think it should be between 1,000 and 2,000 shillings, I think, in a government facility, because every patient who is about to start dialysis for kidney failure has to do it, and many hospitals will test for it before surgery. And in any case, I think the value of doing the test is what much more than the value of
cost.
the test.
Okay. Other risk factors.
One that we are beginning to see more and more, it's common in the West, when you have obesity and high lipid levels, or people say Nikona cholesterol, I have cholesterol. Well, it's not only cholesterol, you have a metabolic problem which can affect the liver and make the liver accumulate fat. And when the liver accumulates fat, it gets kind of like bloated, and we call it steatosis. So that state can cause chronic inflammation, similar to what a virus can do, and then later
becomes liver cancer.
So if you add that with chronic alcohol use, alcoholic inflammation of the liver, the whole cooking pot predisposes you to liver cancer. Liver cancer ranks 13 in Kenya, just below pancreas, with about 850 cases newly diagnosed every year. Again, that is a gross under representation, because many cases will go unnoticed. And the diagnosis, it follows kind of a similar pathway to many cancers of the abdominal cavity. You'd have some imaging test which will show a nodule, which will then be sampled using a biopsy technique, or we'd get a small sample and then it's put in the microscope, and then the pathologist will tell you this is liver cancer. Sometimes they'll tell you, well, I'm really not sure, I need to do more tests to confirm. So we do a second round of tests on the specimen, and then we can confirm that this cancer belongs in the liver and didn't come from somewhere else, because you need to make that differentiation to give the patient the correct treatment.
I mean, if we were to go back to the risk factors, and I know this because most people would commonly associate anything liver with alcohol, right?
Yes, that's true.
So in terms of just in that ranking, obviously hepatitis B is top, but then alcohol, in terms of just, and maybe this is an entirely different conversation, cirrhosis and whatnot, right? But one of the questions I know that I got asked around liver cancer when they knew we were having this conversation was, are there certain alcohols? You know, there's always that question of if you're someone who drinks wine versus someone who drinks
damage to the liver by alcohol is independent of the type of alcohol. So the number of units consumed, the higher the number of units consumed, the higher the frequency of consumption of those units, the more the damage to the liver. What we don't understand is some people get easily damaged, while others have got tough livers that can take anything, and then they're not getting damaged. And maybe this has to do with other factors. So for example, if you have a metabolic issue, you're overweight, you're diabetic, you have cholesterol, and then now you pour in
the alcohol.
So somebody who has a different metabolic profile eats healthy, exercises, and you take the same alcohol, maybe he might be more shielded, but alcohol per se in its own self, if we are considering it as the only risk factor, then the type really doesn't matter.
Okay, fine. So then what's the typical presentation? Or
so because it's in the liver is on just below the right lung, so you normally feel the pain towards the right, discomfort, yellowing of the eyes, any itching, weight loss. Those are the common symptoms that one would get. But remember, when you have symptoms, it's late. There is no such thing as early signs of liver cancer. Absolutely not. If you're on a screening program, for example, if you're hepatitis B positive, we would do ultrasounds every 6 months just to see, are we seeing something beginning to grow? Because you will not feel anything. And that's why you need to be on that surveillance program, because it could save your life. If we find a small tumor, 2 centimeters, and the surgeon can remove it, you're home and dry. And now, believe it or not, we have a long list of liver surgeons in the country waiting to remove those tumors, which we are not finding because everybody is still coming late.
And so then what does it take to get on the screening program? Essentially, you've done, say, a Hep B test. Then, so is it a standard procedure that you will be placed on the screening program?
Well, I know there's a lot of push to have a national government-initiated screening program, which is yet to materialize. So this will have to be on an individual basis. So you and your doctor can enter into that screening program, because it's very important. You explain to the patient the benefits, and then every 6 months there are tests to be done, to be monitored very closely. SA have got a brilliant screening program. In fact, we're having a very big meeting this year in August for the first time in Kenya. It's a consortium of doctors from all over the world who are involved in treatment of pancreatic and liver diseases in general, of which liver cancer is one of them. It will be in Mombasa in White Sands in August. So
invite us. Yes.
This is the official
invitation.
Invite. It's gonna be big. Last year was in Ghana. The year before was in Egypt. And the amount of work that people are doing in this area is so amazing. So I hope this will be the bathtub or the place where some of these programs can germinate, because with a simple screening program, you can impact so many lives.
Absolutely, because then if you think about our population, yes, we talk about most people. I mean, we're having this conversation in Nairobi, but most people are outside Nairobi, so they might not have access to you, right? Even if they come and get the diagnosis and you keep them on a plan, wherever it is, they have to go back home, right? So some communities of support, even if it's not about necessarily they have a cancer, they should be community structures, so that if you are at risk, follow-up can be done from there, right?
That's
true. Okay, fine. So in August we're coming. But yeah, so what about, are there certain profiles? So what determines one line of management versus the other?
So before we go to management, there's one thing I've forgotten, which is also quite topical. It's called aflatoxin.
Yes, good point.
Aflatoxin is a type of fungus that you would find, or rather it's a toxin produced by a fungus that you'd find commonly in poorly stored grains. And this is typically maize meal is the common
Yes, our ugalis and whatnot.
So then comes the problem of the maize meal that is, grinded, and what is making our common carbohydrate called ugali. Is that a problem?
Yes.
We know some regions are affected more. There have been rumors about the eastern province and Cumberland and so on.
Yes.
But it's a potential threat to the whole country. I think our food ministry and people who deal with that area need to comprehensively come and tell us. We have tested aflatoxin levels in each of all these brands of maize meal, and these ones are acceptable. There'll always be some aflatoxin, but not all of it is bad. Some level is acceptable. But we need to know which one is exceeding so that we don't voluntarily ingest a toxin that will lead to liver cancer. It's so sad if a simple, solution can help save, lots of communities. Because you hear, here wamezika, here they've buried somebody with liver cancer, and you are all living in the same place. You are all buying maize meal from the same place.
Yes.
Is it a coincidence? Is it something that we don't know? So that's also something which probably needs to be put out there for our food guys to help us with.
Absolutely. I mean, it also underpins how a lot of it is information we need to uncover, right?
Yes.
There's a lot of research that needs to go into it, and it's not necessarily big research in terms of clinical trials. Great. It's things that are in the community. If we took a bit more time, we could get there, or at least add more local data towards it, right? So yes, around management and treatment, what does that look like?
So, okay, it's usually very complex.
We need a chat.
We need a chat, a blackboard or something. But just to make it simple, so liver cancer, there are various types of treatment which will depend on not only the stage, but how much damage the liver has taken, because the risk factors are different. So we factor in many things. For example, if you are discovered by random chance that you have a nodule in the liver or a growth in the liver, and we can determine through the CT scan that it's likely to be liver cancer, we can't do that. And then maybe it's only one tumor, and the surgeon feels like he can remove that, because there are some parts of the liver you can't remove as easily as other parts. That's why it's very, very individualized. And then if that surgery can be done safely, then you go for surgery, and that's it. What if there are 4 tumors? They are small, they all can't be removed. We haven't seen cancer anywhere else. Maybe you meet the criteria for a transplant and you have a ready donor, then you go for transplant. What if you're a transplant candidate, but you live in a country where there's no transplant? You can't have a transplant.
Exactly.
What if the tumors are 10? The surgeon can't remove them. You can't have transplant. Then what can you do? What if you have one big tumor, 10 centimeters? You can't have surgery. What else can we do? We have so many new technologies. We are using not the microwave for cooking, but the microwave for microwaving inside the liver to kill these tumors. We are injecting the chemo directly into these tumors, and the tumors are shrinking. We're using radio frequency techniques and so many high-tech things that are now available in the country to treat these patients. Sadly, for those who the cancer has probably spread, which is more than 50% of our cases, then would say, can we give you either immunotherapy or something we call targeted therapy, which we all have now locally available. We look at many factors to decide who gets what. There are a lot of cost considerations, but all the options are now available. So I normally sit with my patients and I tell you, it's quite a lengthy consultation, because explaining to you, this is the treatment, this is what it does, this is the availability, this is the cost, these are the side effects. That's plan A. This is plan B. This is the medicine. This one is a tablet. This one costs this much, and then we choose, we decide, and then you do your treatment. after a few months, we take you back for a scan. We see what's happening. And actually, patients are actually responding very well to treatment. So long as we get you before there's too much structural damage to the liver for any medication to make some sense.
Okay, so what would that cost? Because cost is a big consideration. What's the range? I know
it's a wide, it's a wide range. Wow. So maybe, okay, I'll give you an example of one of the very common targeted therapies that we now use very commonly. You could get maybe one of the generics company offering it for about maybe $300, so maybe about 50,000 shillings per month, which NHIF is gladly paying for. So patients are able to access this treatment even in some of the government facilities. There are some treatments like the immunotherapy which could cost a little more, maybe 10 times that cost. So some patients with private insurance are able to access, and those who, their bank balances are there are still able to access the treatment because we have them available, and these patients are responding to this treatment. But it's not a one shoe fits all. Your doctor needs to sit down with a team of other doctors. Usually it's the radiologist, the pathologist, the oncologist, the radiotherapy doctor, everybody. We sit, the surgeon, we don't have to leave them out, we sit with them, and then we all come up and say, based on 1, 2, 3, 4, 5, this is the best treatment for you. It's not something I can decide on my own. It has to be a collective decision.
You mentioned transplant. Are we doing transplant in Kenya?
To the best of my knowledge, not yet. Interestingly, in the strategic plan at KNH, it mentions that we should have been a transplant center by now, but we are set back by a lot of issues that are beyond what I can
systemic issues.
But those are just systemic. But there's really no reason why we shouldn't be doing it. Uganda is moving very fast, and they're probably overtaken us as far as their attempts to do liver transplant. But we hope, because it needs a big functioning team. It's not just the surgeon.
Absolutely.
If the surgeon removes or transplants the patient, and there's no hepatologist, or there's no physician, or there's no pain person, or there's no physio guy, or there's no blood specialist, or it's a big team, so everybody in the team has to be on the
present. So then, and I always ask, and I feel like this is a question I should stop asking in terms of what kind of age profile and whatnot, because we've already identified by now there isn't, but then how does that look like?
Our patients are young. Patients are young. In the last 6 months, probably 90% of the patients I've seen are below 50. And probably it's half are below 40, half are between 40 and 50. We still get from time to time slightly older patients. Again, half of those patients would be hepatitis B positive. The other half, we are looking for a risk factor we are not getting. Because
of course my next question is, okay, what do we need to do? Because the more I listen to you, I'm like, you know what, I need to get all my friends out to be screened. But obviously, there are some things you can do something about, and there are some things you can't do anything about. So one, know your hepatitis B status. If you're negative, get vaccinated. Avoid harmful use of alcohol. Those two things can significantly lower your lifetime risk of getting liver cancer. There are some things you might not change. If you have a genetic defect that has programmed your liver to get cancer by the age of 60, there's nothing you can do about that. Train is moving.
Now, those and obviously maintain a normal weight, BMI, low cholesterol. Make your metabolic profile be the healthy type. Overweight, obesity, high cholesterol, it might be bad for the heart, bad for the brain. It's also bad for the liver.
Okay, so now even last question. All this time you've been coming here, where can we find you? If it's online, how can we find you?
Online, on Instagram, My handle is at @IamOthis, which is the same for TikTok and Twitter.
Amodhis, spell it out for us.
IAMODHIS.
Okay.
Then on Facebook and LinkedIn, it's just my name. Dr. Andrew Odhiambo. And then I have a website, which is www.drandrewodhiambo.com. I teach medicine at the University of Nairobi, and my private clinic is at the Nairobi Hospital Cancer Center.
Okay, perfect. Because I feel like at this rate, I need to direct them just to you because some of these questions, Thank you so much, Doc, for coming. I mean, we'll continue having these conversations. Sure. Absolutely. Thank you.
Thank you so much for having me.
Absolutely. And thank you so much for joining the One Health Lens podcast Explained. We'll see you next time.